If you've been told your joint pain is not bad enough to do anything about yet, or if you've been waiting to see how it goes, or you've been managing it with injections and hoping to buy time, I want you to understand something that most patients do not find out until it's too late to act on. There is a window, and it closes before your joint does. I'm Dr. Tammy Penhollow. I'm a physician specializing in spine and joint care and regenerative medicine, and I work with active adults dealing with knee, shoulder, and spine problems who are trying to avoid unnecessary procedures. What I want to walk through today is something I see in my practice consistently. A patient comes in. They've had joint pain for 2 years, 3 years, sometimes longer. They managed it. They waited. They did some physical therapy, got a few steroid injections, tried to stay active. And now they're sitting across from me, and I'm looking at their imaging and their history, and I'm having a conversation I wish I'd been able to have with them 2 years earlier. Not because they did anything wrong, but because the window for the simplest, most accessible approach has already narrowed. And in some cases, it has closed. Here's what most patients do not know exists. Regenerative medicine is not one thing. It's this range of tools, of which tools are appropriate depends entirely on the state of the joint at the time of treatment. That's the piece that changes everything about timing. Let me walk you through how this actually works across joints. The knee, the hip, the shoulder, the ankle, the small joints of the hand, the facet joints of the spine. The pattern is consistent. At grades 1 and 2 osteoarthritis, early to moderate degeneration, platelet-rich plasma, PRP, is often the right tool. It's the least invasive option. It uses your own blood. It's processed and injected. The data at this stage, 1-2, is strong. Outcomes are good. The joint environment is still responsive. At grade 3, moderate to advancing degeneration, PRP may still be appropriate depending on the joint and the clinical picture, but this is where we start having a different conversation. This is where cell-based therapy begins to enter the picture. Bone marrow aspirate concentrate, microfragmented adipose picture. The biology is being asked to do a harder job in a more compromised environment, then requires more tools. At grade 4, the stage most people associate with bone on bone, PRP alone is not going to produce the outcomes we're working for. The joint's too far gone for platelet-rich plasma to carry the load, unless it's just palliative, buying a little time or just getting you to the next trip through that time before you get the joint replaced. Otherwise, we're in cell therapy territory. And in some grade 4 joints, we're in palliative territory, meaning we can still offer something, we can still maybe reduce pain and support function, but we're managing rather than reversing. And in some of those patients, you just need surgery. Some have refused it, and some cannot have it due to other health factors. And we do what we can. But the point is this: every rung of that ladder that passes represents options that are no longer available to the simpler level. I want to use the hip specifically because it illustrates this better than almost any other joint. By the time we reach grade 3 or grade 4 hip osteoarthritis, the data is not supporting good outcomes with PRP alone. Not intra-articular or with inside the joint PRP. Not even intraosseous, meaning in the bones, approaches the most advanced grades. And this matters because the hip is a joint that patients tend to ignore longer than the knee. Knee pain declares itself. It limits stairs, it limits walking, it changes daily function in obvious ways. Hip pain is a little sneakier. It shows up as groin tightness, as trouble getting into and out of the car, as a limp that gets explained away as a muscle problem for months or years. So by the time a patient with hip pain reaches me and we're looking at imaging together, we're sometimes past that window where the soft tissue work around the joint, PRP to the gluteal tendons, to the hip capsule, to the surrounding structures, would have been sufficient. Now we need to address the joint itself, and the joint at this stage requires more than PRP. And in some cases, the joint is simply not a candidate for regenerative care at all. That's a conversation I never want to have with someone who would have been a strong candidate 3 years earlier if they'd come in then. Several things accelerate this narrowing of the window, and most patients have no idea. Time without treatment is the most obvious one. Osteoarthritis is progressive. Cartilage does not regenerate on its own. The longer a joint's mechanically loaded without support, the further degeneration advances. Repeated corticosteroid injections are also directly chondrotoxic. They accelerate the very cartilage breakdown that is narrowing the window. Every injection that quiets the pain while the joint continues to deteriorate is a trade against future candidacy. Unaddressed metabolic issues like elevated inflammatory markers, insulin resistance, nutritional deficiencies create this systemic environment that accelerates your joint degeneration. They are modifiable, but they also have to be identified and corrected. Waiting without addressing them is not neutral. Mechanical instability that's never stabilized. A joint that's loading asymmetrically, that lacks neuromuscular support, and that is compensating for weakness elsewhere, that joint degenerates faster. Stabilization is not optional for someone trying to preserve their candidacy window. This is what I want you to understand about what's at stake. The window is not just about whether you can have a regenerative procedure. It's about independence. It's about the activities you built your life around. It's about whether the path forward involves a needle or a scalpel. When a patient's in the early window, grades 1 and 2, healthy enough tissue, good metabolic function, we have options that are relatively simple, relatively accessible, and with strong outcome data. As that window narrows, the interventions required escalate. More complex, more costly, more recovery, more risk. And once that window closes entirely, once the joint is at end stage degeneration, and once the structural damage is beyond what biology can address, the conversation changes to surgery, a titanium joint, a fused spine, which is a good option when it's the right option. But it should be a choice made because it's the best path, not because the window for choosing everything else quietly closed while someone was waiting. When someone comes to see me for the first time, one of the most important things I'm assessing is whether they're in this window. Not just what their imaging shows, but how their joint's functioning, how their biology is positioned, what's their metabolic picture, what their tissue quality tells me, and whether the environment is one that will respond. Because the window is not just about grade on an MRI. It's about this whole system. Someone can be grade 3 on imaging and still be a strong candidate because their biology is optimized, their inflammation is controlled, and their stability work is solid. Someone else can be grade 2 on imaging and be a more complicated candidate because their metabolic environment's working against them. And it has been for years. This is why the evaluation matters as much as the treatment. And it's why coming in earlier, before the imaging looks worse or before the symptoms escalate, gives us more to work with. Do not wait until the pain is bad enough. That framing, "it's not bad enough yet," is the most expensive thing I hear in my practice. Because by the time it feels bad enough, the joint is often already moved to the next grade. By the time the imaging looks bad enough to justify action, the simplest options may no longer be on the table. The question is not whether your pain is severe enough to act. The question is whether your joint is still in a window where the most effective, least invasive approaches can actually work. And the only way to know that is to have a conversation before the window closes. If you come in while the window is open, you preserve access to the simplest and most effective tools. You maintain the option for PRP where PRP is sufficient. You keep cell therapy as a step up rather than a last resort. You protect your independence, your function, your ability to stay in the activities that matter to you. You are building toward a more durable outcome with less intervention. If you wait, the joint continues to advance through grades that close options. What could have been managed with PRP now requires cell therapy. What could have been managed with cell therapy may now require surgery. The activities you've been protecting by managing pain may become inaccessible, not because the pain got worse, but because the options got fewer. And the conversation then shifts from what we can do together to what the orthopedic surgeon or the spine surgeon needs to do instead. For some people, understanding this is enough to start making better decisions. For others, they want structure, sequencing, and accountability. If that's you, there are 2 ways I work with people: a guided system designed to help you start improving joint pain step by step, or a more intensive, personalized approach where we work together more closely. Those options are in the description if and when you're ready. I've also put together a free resource, the Patient Guide to Ethical Regenerative Medicine, if you want a clearer framework before making any decisions. And if not, keep learning. That's always a good next step.